Welcome to Conversations in Lung Cancer Research, a TOGA podcast where we discuss the latest breakthroughs in lung cancer research and treatment for Australia and New Zealand. My name is Mel Moore. I'm on the TOGA board, and it's my pleasure to host this series of podcasts. Before we start, Thoracic Oncology Group of Australasia would like to acknowledge the traditional custodians of the land on which we live and work. We pay our respects to their elders, past, present and emerging. We also extend that respect to all Indigenous people. In today's episode, we're joined by thoracic surgeon Dr. Jazmin Eckhaus. Jazmin is an Australian-trained cardiothoracic surgeon with a subspecialty thoracic surgical practice. She has a special interest in minimally invasive thoracic surgery and pleural disease. She has public appointments at Eastern Health and St Vincent's Hospital in Melbourne. She's a founding member of the Binational Australian and Aotearoa New Zealand Thoracic Surgical Database, which seeks to measure and improve the outcomes of patients undergoing thoracic surgery in the two countries. She's a clinical lecturer at Melbourne University and is undertaking a master's degree in clinical ethics at Oxford University with a focus on consent for surgical procedures. I'd like to welcome Jazmin to TOGA's Conversations in Lung Cancer Research podcast. Jazmin, welcome to the podcast. Really great to be talking to you.
Thanks so much for asking me.
Now, I know you've done TOGA podcasts before in more of a group environment, but these ones are a little different in that it's just you and me shooting the breeze, really. I tend to start these ones by asking the people that I'm interviewing to talk a little bit about their background and how they've got to where they are today.
So I started my training as a cardiothoracic surgeon, but I knew from about my second year of training that I always wanted to be a thoracic subspecialty surgeon. And that was because I was really inspired by some of the thoracic surgeons I worked with about the range of things they could do and the fact that they were really true surgical oncologists. So that's how I shaped my career. After completing training, I did subspecialty fellowships in thoracic surgery and minimally invasive surgery, oncology and robotic surgery. And now I work as a thoracic surgeon at Epworth, St Bees Public and Private, and at Box Hill.
So, Jazmin, I'm guessing there's probably a high proportion of physicians that are listening to this. Just to give us some context, what sort of length are we talking about there for that sort of training that you've mentioned? How many years from where to go?
Oh, it makes me feel so old when you ask that. Training for me was 7 years and then 3 years of fellowship. And that would be considered a pretty speedy, pretty good amount of time to spend.
Yeah, wow.
It's a really long time, isn't it?
Yeah, it really is. It really is. You got to go through general surgery first, I assume, and then branch off into cardiothoracics, or can that happen quite early on?
Yeah, so I was one of not the first, but the middle of the range where they just stopped doing general surgery. So I'm not trained as a general surgeon. So I don't do any esophageal work because I think the general surgeons are much better at that than me. But it also means I was really lucky in that I didn't spend any time doing things that for me didn't really directly relate to what I wanted to do. So although I've said, it's a really long time, it was a really great time because it means I felt like I saw so many of the unusual things at least once.
Oh, that's great. You mentioned that you were attracted to thoracic surgery really because of an interest in oncology. What about oncology and oncology patients with thoracic malignancies was appealing to you?
It's such an interesting question because I imagine my answer might be quite alien or quite bizarre to the actual oncologists, including you listening. When you come from a surgical background, what you're looking at is a bit different. And I found the oncological side just really interesting. Obviously, this is a fantastic time to be involved in lung oncology. So I could just see it was exploding in front of our eyes. Things were improving and changing. And as a surgical oncologist, you have this lovely defined role. It's not like cardiac surgery where you don't really have much to do with the patient, but it's not the same, to me, burdensome role as an oncologist where you're there the whole time. You get involved, you understand the disease, you can really try and help modify and change the disease course. And then you have all the assistance of your friendly oncologist to help you manage the rest.
That doesn't sound like an alien answer at all. I completely get that and possibly envy you a bit in some ways.
Well, my answer doesn't mention targeted therapies, TKIs, molecular biology. That wasn't quite the reason for my choice, although those things are really exciting.
Yeah, no, they absolutely are. I wanted to talk to you first. You mentioned that you've done a fellowship in robotics, and I correct me if I'm wrong, but I think last year you performed the first ever robotic lung surgery at Epworth Eastern. Have I got that correct?
Not quite correct, but that's because there are 3 robots, so it's becoming this sort of increasingly confusing space. So we have the multi-port Da Vinci robot, which was really, there are lots of surgeons in Melbourne who've really pioneered that and done amazing work. Then we have the robot bronchoscopy, which is only at Eastern in Victoria and is really fantastic for biopsying peripheral lesions and for marking peripheral lesions. So from my point of view, it's a tool to help minimize the amount of lung resected. And then what we have is the new single port robot, where we've only got one in the Southern Hemisphere, and that's at Epworth. And I was really fortunate and really excited to be the first surgeon to use it for thoracic surgery. And I did a really interesting bronchogenic cyst and then an anterior mediastinal mass as the first cases we'd done in the Southern Hemisphere.
And how does that, apart from the obvious of being one port versus multiple ports, how else does that differ from the Da Vinci multi-port that you mentioned?
Yeah, the tech team have tried really hard to try and make it from an operative point of view as similar as possible, but the instruments are all smaller and finer and the view is fantastic. Surgery is a simple profession. The biggest difference is that it's a single port, and I've just been amazed at the difference in pain. So for even very large and complicated mediastinal masses, the little incision is like the top of a laparotomy wound. So it's 3 centimeters and it's below your xiphisternum. So what we've done is get rid of the intrathoracic incisions, which are really the cause of pain. So I knew we were on a winner with my first patient. When I went to see her at 8 in the morning, how did she survive this new exciting operation? She was up and making the bed. And you don't know, maybe that's 1 in a million, but actually the results have continued to look like that. So another patient who was definitely never going to be making any bed because that was not in his set of skills. But a week later, he was so fit and well and recovered so well that he could have chemo and radiation, which is what he needed for the rest of his cancer treatment.
Wow, amazing.
So it is just getting rid of lots of cuts, but allowing you to do the same operation.
And do you think that's the new future where most lung cancer resections will go, pending availability of the hardware?
I guess there's 2 things. We always have to be realistic. You can't get a 10 centimeter tumour out of 3 centimeter cut. So there are always going to be cases and cancers that are not appropriate for minimally invasive technique. And surgeons never done the wrong thing if they've got a big tumour and they've done a big cut. And at the moment, the technology is not as good for the single port. It's really new. So I'm not doing any really complicated cases. I think they're still more appropriate to be done through a more conventional multi-port technique. But it certainly, I think, will probably be the way we approach particularly anterior mediastinal work and some posterior mediastinal cases.
So as a non-surgeon, VATS surgery blows my mind in terms of the small incisions and what can be removed. So robotic is just a whole nother level. Can you, for people that aren't familiar, including myself, just describe how does the room look? Are you sitting anywhere near the patient or are you quite distant? Who's in the room? Who's out of the room?
Yeah, it's crazy. And it's something that's very hard to adjust to as a surgeon because obviously with VAT surgery, video assisted, I'm standing at the bed, I'm doing the operation, my hands are there, and it's just what you're used to. It's how you grow up. For robotic surgery, you're sitting at the console, so you're not scrubbed, you're not at the table. And for safety reasons, for thoracic surgery, we always have someone qualified who's sitting there, hopefully being really bored, thinking, what a way to waste my own life, just in case something happens. But there have been cases overseas where surgeons have done cases from different countries on the robot console, which is really scary, isn't it?
Wow, that's incredible.
It is incredible. And it's hard to communicate. I had one patient recently say, robotic surgery sounds really good, but do I think it would be better if I did the surgery rather than the robot? But we're not quite there yet.
What did they mean by that, sorry?
So their impression was that the technology, that the robot would be doing the operation.
Right, okay.
And I did have someone describe us as robot workers, which sounds like something out of Asimov. But I think as the technology gets more and more confusing and as people get more and more used to AI, some people find the interface a little harder to understand. So I have to reassure everyone listening to the podcast, the surgeon is definitely doing the operation. If I don't move my hand, the robot doesn't move. But I think for some of the patients, that's not obvious.
And so who is actually inserting the port in the operating room?
So I always do that. So I scrub, we prep and drape like normal, we put the ports in the right position, put the instruments in, make sure everything looks good, safe to proceed. Then I take off my funny outfit, I sit down at the console. Much to the disgust of some of my anaesthetists, I often take off my shoes, which is lovely. And then I do the operation and then I scrub back in at the end just to put the drain in, make sure everything looks really nice, make sure the cuts look really nice.
And from a time point of view, is this a shorter or a longer procedure than a standard VATS procedure?
Like everything, it's got a learning curve. So certainly in the beginning, it took a longer time. Now what I find is I'm doing more and more of my really complicated work robotically. So then the time is evening out that VATS in robotic take similar amounts of time.
Well, what do you think are the main barriers to this being rolled out more widely? I guess I've just said potentially cost, but I'd imagine there's others.
Yeah, cost is a really important one. And it's really important, I think, to be realistic that there isn't an infinite amount of money. And sometimes I think particularly surgeons behave like there is, and we just do all the things we want to without thinking about all the flow-on effects. I think robot surgery is going to become more and more common. So more and more of the public hospitals have a robot. But I think we need to really ask good questions about the benefit of robotic surgery. And I'm part of the REVILE trial, which is an international trial where we're looking at whether it makes any difference to quality of life, whether you have VATS or robotic surgery. And I guess it's important to remember that across the country and particularly overseas, the question isn't VATS or robotic, the way sort of the default is in Melbourne. It's open or robotic. And that's a huge difference. So the arguments about whether robotic is better than a big thoracotomy, I think are much clearer.
Absolutely. And so you mentioned the trial about quality of life outcomes, but is that same data there for cancer outcomes between robotic and VATS?
So all the data at the moment would suggest the outcomes are the same, so that robot is not inferior. Some people would suggest that there are positive differences favouring robotic surgery, but I think what we see is a patient who gets a really good operation regardless of how you do it.
So I'm just going to change tack slightly, and I guess outcomes is a good segue. I mentioned in your bio that you're a founding member of the ANZ Thoracic Surgical Database. Could you talk a little bit more about how that came into being and your role in that, Jazmin?
I think it's an amazing story. I was actually thinking about this yesterday in a different context. We realised there's a group of surgeons who are all active practising thoracic surgeons, and we realised that if someone asked you a really difficult question like, how many thoracic operations happened in Victoria last year, no one could possibly answer that question, let alone anything that would actually be difficult. Do people do a good job? Are our outcomes good? Are there lots of people doing thoracotomies? None of these things we could answer. So that was really the impetus to try and create the database. And then I got locked down in one of my fellowships in New Zealand. And so I spent that time besides operating and then coming back to my very quiet, very cold house in New Zealand and doing the ethics. And I was just thinking what an amazing thing to grow out of that experience. And the fellowship was great. And, it's a complicated thing, especially as someone who's very early career when it comes to research, to write this kind of ethics process. And it's taken us years and years and years, but we're getting more and more traction. And more hospitals and institutions are enrolling every year. And if anyone is listening and they're not sure if their institution, if their surgeons contribute data, you should ask them. And we've worked really hard to make it a really good clinical quality registry. So we don't want to produce a report, and the data is still immature because it's early days, but we don't want to produce a report that just says something like 2% of your patients died, so you're doing really well. We've tried to be really thoughtful and selective about what are the true key quality indicators in thoracic surgery and trying to look and address and see whether they're being met, knowing that, of course, nobody achieves them all the time.
And it sounds like it's up to the individual sites to enter their own data. Is that fair to say?
Absolutely. And that's always a problem. Entering data is time consuming. It's costly, whether it's your time or someone else's time. And it can be really burdensome. So that's the biggest limiting factor for the database. We do have the ability to ingest data. So people who work with an EMR, we can certainly use that. But yes, and it's opt-in.
And how has it been received? Has it been viewed favourably and good uptake thus far?
Oh, I guess I'm a founding member of the data custodian, so no one's going to tell me if they think it's a terrible idea.
But word might get back to you, I don't know.
Oh, I don't think so. People are nice. The uptake's slow, but that's what you expect with something like this. But what I've been really excited is it's a rolling ball, and you can just see more and more sites are joining. It's really exciting.
And have you modelled this on other countries, like are the US and Europe, are they doing similar things in terms of clinical quality registries in this area?
Yeah, so part of the creation process, I reviewed all the different registries and databases that I could find papers about, and there's lots and lots of different models. And we just tried to work out what would be simple, user-friendly, but also the most valid model.
It sounds crazy when you say it out loud that we don't have that data on hand already, because data is just so crucial for auditing your own centre's performance, but research, so many things.
It's absolutely crazy. And I still can't tell you this is exactly the number of thoracic cases done, but we will get there.
Yeah. And I think I read that the cardiac surgeons have a quite as well-established database, but...
Absolutely. They were absolutely pioneers and very well established, almost 100% uptake. And we certainly learned from their model, from the way they'd done it, because they did lots of things really well.
Yeah. Oh, that's a fantastic initiative, and all the best, and hope everyone out there listening thinks that's a great idea. Let me sign up.
Oh, thanks, Mel.
Now, in your spare time, you are also doing a master's degree in clinical ethics at Oxford.
I finished.
You finished. Congratulations.
Yep. Thank you. I managed, the thesis was marked, which takes about 6 months at Oxford for someone to read your dissertation and then give you a mark, but all done.
Fantastic. So where did that come from? What was the motivation for that?
Looking back, clearly it was pure madness. But I did philosophy as an undergraduate at university. And for me, in some ways, it wasn't quite the fork in the road, do philosophy or do medicine, because I was pretty practical about the job prospects for academic philosophers. But I always had that passion and that interest. And I always said, when there's time and space, I'm going to come back and I'm going to do more philosophy. And COVID and fellowship, I thought, was the obvious gap, which in hindsight was a good choice, but maybe not a great choice, but always wanted to do it. And then I had a look at all the different degrees. And because of COVID, everything was online, everything was really available. And so doing a master's at Oxford with these amazing world-leading philosophers and ethicists was a really viable option.
I'm assuming that you were specifically looking at ethics for surgical procedures. What was your gripe or your particular interest in that was the research question you were seeking to answer?
Yeah, so to apply, you had to submit a dissertation proposal, and it's really interesting. It takes years. I'm sure you've done a PhD and know much better than me about how iterative the process is. But really the core thing I wanted to address didn't change at all over the years. So I was always interested in consent and the process of consent, because I always felt the way surgeons are taught about consent or taught to think about consent really lacks nuance and in some ways is really dysfunctional. And I think you can see that in everyday examples when you think about a patient who refuses care that you think they should have. There's lots of questions, there's lots of process, lots of agitation. But if a patient agrees to care for really silly reasons, but you think they should have it, then there's no issue. So it seems like the process is not that important. In some ways, it's just the answer. So I wanted to dig down into the principles we're taught and see if they are really good for purpose. And if they weren't, then I wanted to have a think about different ways we could approach consent and try and come up with something practical, because at the end of the day, consent is a practical thing. It's not an academic process.
And did you actually do this with actual patients and examples?
No. So the joy of philosophy is no ethics required, no studying people. It was quite hard, actually. I applied for some funding and people were saying, will there be rats and what experiments are you running? And trying to say, oh, actually, I just want you to buy my time so I can read things and then think about them. It just doesn't go very well. But that is the process of philosophy. It's hours and hours of reading and then thinking about it and then arguing, which I thought was wonderful. Very different from my real life.
Very nice way to spend some time, I think. Do you think at the end of that, can you see a practical application for it?
Absolutely. I think it's worth saying that my feeling didn't change after doing all the reading and thinking in the principlist model that we're all taught in med school, autonomy and beneficence and non-maleficence, is not actually good criteria for consent, and that Beauchamp and Childress' framework for consent is pretty limited. So what I landed on as a better approach is what's called a relational approach, which many of us, if not most of us, are already doing to different degrees, but it's more about formalizing the process and saying this is a better way to arrive at a good decision.
And have you changed your practice as a result of that?
I came into this having spent literally decades already thinking about it, so it wasn't a huge shift. I think it's made me stricter about some things. So if a patient says, oh, I'm not sure, I say, no problem. It doesn't matter how many patients there are in outpatients. And I'm so lucky my colleagues don't hate me for this. I say, come back next week. Bring your whole family. We'll talk about it, because it made me more insistent that people shouldn't be pushed. And in my private practice, I'll often say, take home the consent form. If you want the operation, return it. And if you don't want the operation, that's fine. And I always have a mechanism to make sure they're not lost if it's a cancer situation. But it's just about making more space, because often, particularly in thoracic oncology, but in many of these decisions, we know what the right answer is and we just want the patient to get to the right answer as quickly as possible for their health. But I think ultimately that's not the right thing to do.
And I'd imagine that you're probably mentoring junior thoracic surgeons or junior surgeons now in that similar sort of approach.
Well, I do a formal lecture series for some of the Monash students, and we do a lecture on consent once a year, which I'm never sure how well it lands. But I think in terms of mentoring, I just start with the basic things, making sure people understand, that you explain to them in whatever way the patient can understand, which can be really complicated with some people who have very limited education, no English, difficult translation setup, and then making sure patients understand they have options. And also because I do think the relational approach is the best approach. I don't know what you were taught in med school, Mel, but I was taught to tell them, no, only one family member in. But now I absolutely encourage 50 family members to come in. And the more I think about it, the more I'm bewildered that anyone would say to leave them. Because part of being a doctor, you learn lots of different complicated social skills. And managing a room with lots of people is not the most difficult thing any of us do. So if someone is lucky enough to come in with 5 children and 6 grandchildren and aunts and uncles, all who care and want them to get a good outcome, they should all come in and listen. And you can just say to them, you can't all talk at once. That's very reasonable.
Yeah.
So yes, that I encourage everyone to do.
That's a great approach. Absolutely. So you said you did philosophy as an undergrad. Am I safe to assume you did a BA as your undergraduate degree?
So I started a BA and converted to a diploma of philosophy because I wanted to finish med school quicker and it saved a year.
Okay. So this was concurrent with med school?
Yes, that's right.
Wow. That's an amazing combination of practical and cerebral skills to have.
It was so good. It was hard sometimes. I wasn't a very organised student, but it was so enjoyable and rewarding. And, doing history for summer school or doing anthropology was amazing.
Yes, no, the reason I asked, I've got an undergrad BA and a Bachelor of Science, and I absolutely just loved my arts degree. Highly recommend.
What was your major in?
I did political science and English lit.
Oh, wow.
Yes.
Those were actually harder subjects, I thought, because you had to do all that reading for English lit.
Yes, yeah, which I loved. So that was all very
so
nice. Now, I was looking on your website, Jazmin, before coming to record this, and you mentioned on your website that, and correct me if I've got this wrong, this is not accurate, but you are the only practising female thoracic surgeon in Australia.
That is correct, but I want to be really clear. There are lots of really, or not lots, there are definitely amazing female cardiothoracic surgeons practising across Australia and New Zealand, and there's many across in Victoria, but I'm the only woman I know who's a subspecialty thoracic surgeon and doesn't do any cardiac.
Okay. And why is that unusual? Like, why is that, do you think?
I don't know. Thoracics is so much better than cardiac. They must be a bit silly, right? I think it's probably lots of things, right? People are not as interested in thoracic. Sometimes when you do cardiothoracics, you want to be a transplant surgeon, you want to be a heart surgeon. And I think it's not the common path. If you're happy to just go with the flow or you don't put a lot of thought into it, you'll just end up doing what most people do. But you have to really pick thoracics if you want to do pure thoracics.
And do you think it will continue to be a combined program, or do you think there's a chance that it actually becomes 2 separate programs? I imagine the skill set's a bit different for each.
I'm really glad I did cardiac surgery. I think it's really improved my technical abilities. But we have been talking about whether it should be split for years and years and years. And I'm sure they were talking about it long before I ever got on that training program. Some countries have already split, and I wouldn't necessarily be surprised if that happened. On the other hand, there are differences in Australia compared to, say, China or Taiwan in terms of geography. And I think particularly if you think about Queensland or WA, the distances are so vast that probably makes less sense to have a workforce that's subspecialised. So I think it'll be really interesting to see what happens.
Yeah, absolutely. I'm just going to go back a couple of steps because you did mention robotic bronchoscopy as well. And I remember at our Toga ASM last year, we had Kelvin Lau come and do an amazing presentation. It was incredible how far into the lungs these robotic bronchoscopes could get. Is that something that you think, like robotic surgery, is going to become more prevalent?
I think it probably will because, and this is just me guessing, I think that we're more and more going to move away from long-term surveillance. So I'm sure we'll still have short-term surveillance of pulmonary nodules to make sure they're not going to go away. But I think for nodules that aren't getting smaller or going away, we're more and more going to say we need to know what it is. And so I think as that demand for earlier biopsy for harder lesions increases, I suspect robotic bronchoscopy will play a bigger and bigger role. I am terrified, though, that they will work out how to cure cancer bronchoscopically. So I hope that doesn't become a thing. And as I alluded to before, marking with coils and dye via robotic bronchoscopy is a fantastic addendum to surgery.
And is there a demarcation here? Is it a bit of a fisticuffs between the respiratory physicians and the thoracic surgeons, or are you both going to have the skills in that area?
I hope it's not fisticuffs. Kelvin's a surgeon. He's a fantastic example. I think with new technology, it's always about who has the skill set and who's interested to pick it up. And certainly I work with fantastic and really highly skilled respiratory physicians who are doing a really amazing job at really championing robot bronchoscopy. I have done the training, I'm credentialed, and I do think it's an important skill for surgeons because I think you can't be asking your colleagues to mark something, particularly that's already been biopsied. And I think it's just really helpful as a proceduralist to be able to offer the full range of procedures as required by the patient.
Yeah, for sure. Just before we finish up, you mentioned that you finished your dissertation. What do you do in your spare time to unwind? How do you, I imagine you've got a little bit more time now that you're not doing a thesis.
Oh, it's amazing. Steve Barnett told me once you finish for the first week, you'll be like, oh, amazing, I've got so many extra hours in the day. And then 2 weeks later, they'll all have vanished. And he is pretty correct.
Vanished with work-related things?
Oh, not always. I really enjoy, I've got 2 dogs. I love walking them. I love going to a gym. And I love really eccentric, complicated cooking projects like making pickles or preserving things or things like that. And I love just being in the kitchen and just pottering around.
Fantastic. Are you like me that you need to have every single ingredient that's listed on the recipe and can't deviate?
I don't mind making a planned deviation, but I do need to have them all out on the bench before I start. Otherwise, something will be left out because I'll be answering my phone and listening to a podcast and chatting and cooking, which I suspect you're more organised than me when you cook.
No, I'm a bit of a messy cook, to be honest. Jazmin, it's been a real delight. The thing I love about these podcast is just learning so much about where people have come from, what their passions are, and particularly across the different craft groups outside of oncology. It's been really fascinating hearing about not just your robotic surgery, but setting up a database, your interest in ethics. It's quite amazing the breadth of your interests and expertise and knowledge. So it's been a real pleasure, and thank you again for taking part.
Oh, it was really my pleasure, and it's really lovely to be asked. So thank you very much, Mel.
That brings us to the end of this episode. Thanks again to Jazmin for joining us today. As always, thanks for listening to TOGA's Conversations in Lung Cancer Research. If you enjoy our show, please rate and review us on Apple Podcasts or Spotify.